Today's episode of the podcast is all about anterior pelvic tilt. We're going to go through what it is. We're going to go through how it's diagnosed. We're going to go through some specific experience we've had over the years with this, because there are problems with anterior pelvic tilt, both in the way it's diagnosed and also problems that it can actually have for your lower back, and why it's often diagnosed alongside lower back pain, and then how there are really effective ways to reduce and eliminate your anterior pelvic tilt. But often that's just done in a very haphazard way, and it can result in problems the other way. Cue posterior pelvic tilt and the consequences of that, which can be particularly detrimental for your lumbar discs and recovering from any sort of disc injuries down there. So hopefully by the end of this podcast, you're going to really understand anterior pelvic tilt. And there's a kind of a little disclaimer towards the end of the episode where we cover some specific exercises. Please, if you think you've got anterior pelvic tilt, make sure you have it confirmed precisely how much beyond a normal alignment of the pelvis before you go ahead and do some of the exercises that we talk about, because they do work. They will eliminate it, and we'll get onto more of that later on. So let's start the episode out. And before we do, any questions that you do have, post it in the comments, because I know from previous videos we've done on this sort of topic, we do have questions, we do have things that maybe aren't clear. So please do use those sections, whatever platform you're on, and we'll read and respond to all of those comments and questions that you do have. So let's start off with what is anterior pelvic tilt? Anterior pelvic tilt is basically, we've got our pelvis, which is going to consist of sort of the two bones on the side, the innominate bones. We've got on the back, we've got our sacrum, and you can see that on the spine behind me here. And then on the front, we've got the pubic symphysis. And essentially, that should be in a set position, which allows for the lumbar spine to come out of there and then form the lumbar lordosis, the neutral position of the lumbar spine, which is with a slight backward bending curve. And then it goes on up through the thoracic spine and so on and so forth. And that is the neutral position. Now, we will go into anterior or posterior pelvic tilt numerous times during the day. If you were to bend over, for example, with a hip hinge movement, you're going to anteriorly rotate your pelvis as you lower yourself down. If you were to sit slouched in a chair, you're going to posteriorly rotate your pelvis as you flatten out your lumbar lordosis. So it's changing all the time. The problem arises with anterior tilt is when it's a postural habit, if you will. When you stand up and you allow the front of the pelvis to tip forwards, you allow your bum to essentially stick out backwards. And often you find with these that the lower abdomen, so below your belly button, kind of feels like it sticks out a little bit more. And it always sticks out when you stand up and you don't really know why. And that's one of the cues perhaps that there's something going on there, but it could be a number of other things. And the important thing to note with anterior pelvic tilt in most cases, you can consciously correct for it. So you can just do a posterior pelvic tuck. The issue arises there is if we're going too far, etc. But learning how to stand correctly is really quite important, and we'll touch on that a little bit later on. So that is anterior pelvic tilt out the way, and you're essentially tipping your pelvis forwards. If you imagine sort of having your abdominal contents and you're kind of tipping those out the front over the pubic symphysis, that is what anterior pelvic tilt is. It will result in a couple of things. Number one, as you go into anterior pelvic tilt, your lumbar spine has to curve backwards more. And in that position of curving backwards more, the facet joints on the back part of our lumbar spine, those kind of engage a little bit more. So we have less spring. If you imagine the curve in your lower back, as you increase the curve, the facet joints come together again, or they come closer than normal, or in the neutral position. The holes where the little nerves come out, which we've touched on many other episodes in the past, those get a little bit smaller. Cue things like sciatica, where the nerves get compressed. You can think about that there. Additionally, because the pelvis is tilted round forwards, the slope that your lumbar spine sits on via the last lumbar disc, the L5S1 disc, now becomes steeper. So now we've got an increased slope, and that's going to create forces of shear through that lumbar disc. So that's something to think about. Your sacroiliac joints, as you rotate forwards, they become, relatively speaking, more engaged and locked in. So you're going to have slightly less play in the movement as movement goes through the spine, down into the hip and on into the lower body. So that's some things that are happening when you have anterior pelvic tilt. Why does it happen? Well, there are a number of reasons. As I mentioned already, we're thinking about the posture. We're just not standing correctly. We're allowing our pelvis to rock forwards rather than having this sort of resting engagement. And people often say, oh, well, there's no bad posture and things like that. And, it's too much effort for me to change my posture. But your posture is a habit. It's the way in which you stand. And if you look at 10 different people, they're all going to have slight different postures, and their bodies have adapted to those strains. It's a subconscious decision, but it can be made a conscious decision for a period of time to improve the way we stand, so we're not standing with our anterior pelvic tilt. And then over time, that becomes a subconscious pattern. It's just the way we hold ourselves. And there's so much variation within the population in terms of how people naturally, comfortably hold themselves, that you can see that it is something that can become subconscious, and it just requires a little bit of learning and a little bit of changing. But some factors that affect or that have a significant effect on the anterior pelvic tilt are going to be things like your hip flexors being very, very tight. Now, the psoas muscle, and to a slightly lesser degree, we've got the rectus femoris muscle and sartorius, which run from the front of your hip, and in the case of the psoas, from the front of your spine. And if we're sat all day, as many of us are, and we've touched on this in previous episodes, sitting for, I think it was 8.5 hours a day, or it might have been slightly longer, that we quoted in previous episodes, the average adult, that is, those muscles are going to tighten up. So when you go to stand up, they're going to restrict your hip extension, that is the hip moving all the way backwards. And so to allow you to stand up, or to accommodate for that lack of extension in the hip, they pull your pelvis round forwards. And that has the effect of pulling on the front of the pelvis and helping that anterior pelvic tilt occur. Additionally, if we've got weak core because we're sat for long periods every day and we're not doing any proper training, then we're going to also allow that process to happen, because our rectus abdominis muscles and our core control just allow the pelvis to rock forwards, because they don't pull up on that pubic symphysis on the front to prevent it from rocking forwards in the standing position. Additionally, we might have weakness in our hamstrings and our glutes because they're not being used effectively. So they allow that tight muscle to pull everything forwards. And we'll kind of get to what are we going to work on to fix this sort of thing later on in the podcast. But we're already getting perhaps a few ideas. We've got some weakness in the hamstrings. We've got some weakness in the glutes. We've got some weakness in the rectus abdominis muscles on the front, overlaid with a lack of conscientiousness about how we should be standing, or how we should not be, or how we should be resisting that anterior pelvic tilt. So that's something to think about as well. But that's fundamentally how the anterior pelvic tilt comes to be. And I think the big thing with this is having that conscientiousness and that awareness that it is happening, and then taking steps, as we'll discuss later on, to override that. Now, the big problem that I've always had with anterior pelvic tilt is it's too readily diagnosed, and that's quite important. I think we need to touch on this for a little bit here now. Now, the first thing with the diagnosis is we've seen many people, you're talking about thousands and thousands of lumbar spines and pelvises that have been analyzed on imaging. And when I'm talking about imaging, I'm not talking about a photograph, okay? That reading back through the accompanying article here, sometimes when we're referring to imaging, you might be forgiven for thinking we're talking about taking a photograph, because some people will measure that way. They'll take photographs, they'll use certain bits of software to try and measure from a photograph the degree of anterior pelvic tilt, and it's just not very accurate if that's being done. But most cases, it's just an eyeball and pressing on some bones and trying to have a look to see whether it's tilted or not. That's not accurate. In our experience over the years, we've been doing proper imaging, so standing load-bearing x-rays, to assess the anterior pelvic tilt, whether it's there or not. And not 9 times out of 10, but a significant majority of people that would come into the clinics, we would see them, and they have been told numerous times, oh, you've got anterior pelvic tilt, that's why your back's sore, etc., etc. The reality is they don't have anterior pelvic tilt. And I talk about this in the article. If we're going to be charitable, we could say that, oh, they were diagnosed with anterior pelvic tilt 12 months ago, a year ago, or whatever that case may be, and they've been given the exercises and they've done them so well, they now have a posterior pelvic tilt. That is the charitable case, which I don't think is true. What's more likely is they were diagnosed with them relatively recently, because that's often the case, and they don't have it because there are all sorts of illusions that can take place on the surface of the body that can lead to the implication that you might have anterior pelvic tilt, that can trick the person into thinking that they have anterior pelvic tilt. So number one is going to be the way in which the soft tissues hang over the body, over the skeleton. When we're looking at a postural exam, and this is the biggest weakness with anterior pelvic tilt diagnoses, and why so many people don't actually have it, and then they get into exercises that do work, and then they create a real problem that they have, which is something that we'll get into later. But we do a postural exam. We look at the glute. Oh, the glutes stick out a little bit, and then it goes into a nice deep curve, and we think, oh, you've got too much lordosis there, and therefore it must be anterior pelvic tilt. That's one of the cues I've mentioned already. Maybe the stomach's sticking out a little bit when you're standing up. You think, oh, that might be anterior pelvic tilt. It's not particularly fat there. It's abs, but it's sticking out a little bit more. Maybe that's anterior pelvic tilt. And then those create illusions on the surface, and maybe that's not actually the case of what's going on. It's just we're not perhaps having appropriate core control, etc. So those are some of the illusions. Another more detailed issue that I've seen, and this is only identifiable on imaging, and it kind of plays into the issue of the person looking like they've got too much curve in the lower back, the very lower lumbar spine, is the person who has a posterior pelvic tuck to a degree. So they're actually flattened already. So that's the wrong way. They're going the other way, too flat. But they have a hinge point at the lumbosacral junction. And then they have a flatter than normal lumbar curve. And this is a bit peculiar. It takes a bit of effort to get into this position, or a bit of misfortune to get into this particular position. But what they have is they have a very straight spine, and they have a hinge point at the lumbosacral, and then they have pelvic morphology, which is posteriorly tucked, and it creates the illusion that there's a deeper curve there because they're swaying back as well. So that's another one. And then you give that person posterior pelvic tuck exercises, and you just make them a whole load worse. It's a little bit more complex and needs a better understanding, but that's one of the illusions that can sometimes be picked up on the surface. Oh, it looks like you've got too much curve. And then when you look at the spine, you understand it in a whole different light, that actually there's a bit more going on here. And the biggest problem with this is that when you get diagnosed with anterior pelvic tilt and you don't have it, because you've been diagnosed with anterior pelvic tilt from physical examinations without any proper imaging, proper load-bearing imaging, or worse still, you've been diagnosed with it while you've been lying down, which is a whole other issue, it's really inaccurate, but the exercises work. And therefore, time and time again, we would see this clinically. You're diagnosed with exercises or given exercises to deal with the diagnosis that you don't have. And then you start to run into problems because those exercises do posteriorly tuck your pelvis. They do end up making changes to eliminate a hyperlordosis. But if you started with a normal lumbar spine, perhaps, and you didn't have any alignment issues, because the vast majority of us don't have alignment issues because we are of normal alignment. We've just injured ourselves. And perhaps there are some other muscle issues that aren't, that are corresponding to a lack of ability to get better. We don't have good control. We don't move properly. We're not, our lifestyle issues are there as well. But you start doing these exercises and they do work. And now all of a sudden you had a normal spine and you've given yourself a reduced curve. And that's a real problem because that means there's more pressure on your discs. You've disengaged your sacroiliac joints. You find you're straining them regularly. There's instability there and you're fundamentally undermining a disc injury that's perhaps in the lower lumbar spine, that you keep doing these posterior pelvic tucks because you got told you have anterior pelvic tilt. And it creates this vicious cycle of someone who gets really, really tied in knots, and it's a real problem. So that's kind of covering the issues with the diagnosis. And I won't go into that anymore with the fact that you probably don't have it, or there's a very good chance you don't have it from our clinical experience. What if you do actually have it? It's verifiable. Why is anterior pelvic tilt going to be bad for you? Well, number one, as we mentioned earlier, you're approximating those facet joints in the lumbar spine. So if we start in the impacts in the lumbar spine first and then work our way down, you're approximating those facet joints and you're eliminating the way in which the spine can work. So if we load bear on the spine, it's going to kind of absorb a little bit of shock. The curve is going to increase. If it's already increased, it doesn't have much more increasing to go before those facet joints start to really abut one another. That's the first thing. Secondarily, because we've got the anteriorization of the pelvis, our body weight tends to, not always, but it tends to shift forwards, which means we shift forwards a little bit, stick our bum out. Now we have more load of the torso. Because the torso is no longer balanced, top over the bottom, the torso is shunted forwards. We have more physical demand on the musculature and compression through the spine on a daily basis, day in, day out. And that shifts a little bit more pressure. We think immediately, oh, too much curve in the lower back, loading the facets. But now because we're leaning forwards, we're also going to be compressing those discs, particularly most pronounced at the L5-S1 junction, which already sits on a slope. The disc kind of sits on a slope there, and then we go into the lumbar spine. If we make that slope steeper, now we've got more shearing forces that are taking place at the level of the lumbosacral junction. And that's one of the big concerns that people have with this particular condition, is looking into things like spondylolisthesis, and that's where the vertebra literally slip forwards. The discs are very, very strong. We have a great body and it is really, really resilient. But discs are meant to deal with compression, not shearing forces. And they particularly don't like that at the L5-S1. And if you're particularly unfortunate, maybe it's translated into the L4-5 as well. But it is more common for forces to localize or focus strain specifically to that L5-S1 disc. And then we get an MRI or an X-ray image and we go, oh, you got more wear and tear, but that's normal. That's because you're old. And we've covered that in previous episodes. It's just a silly statement. There is a number of factors, or are a number of factors, that focus strain onto the L5-S1 disc when we have that anterior pelvic tilt or segment as a whole. And that's a real problem. And we want to eliminate that by adjusting the alignment of the pelvis, which can be done, as we'll get onto later. So we've got strain on the facets, we've got strain on the disc. If we then have an injury, because often you'll be walking around with anterior pelvic tilt for a long period of time. You've often had it without trouble. But when you do have an injury, we then have these other factors at play. We've got more compression through certain areas of the spine. We've got the facets which are approximated and therefore making the holes where the nerves come out smaller. Let's assume we don't have a spondylolisthesis because we've covered that in a separate episode, but that might be a factor as well, which is going to affect the holes where the nerves come out. Then we wonder why we have sciatica, because any little amount of inflammation that builds up in that lower lumbar spine from the strain that's there on the disc perhaps, or on the segment at large, that's going to fill up those holes very, very quickly. So what do? Well, we immediately try and lean forwards further. But we already mentioned that our torso is shifted forwards. So now we shift it forwards more and try and flatten the lumbar spine out a little bit, or just redistribute ourselves. And we find we can't straighten ourselves back up again, because as soon as we straighten ourselves back up again, those holes get smaller, and that puts us into a further off balance position, which puts more pressure through the spine, which puts more strain on the muscles because we're stood in an inappropriate manner with our bum stuck out and our torso pushed forwards loads, and it starts to have knock-on effects up and down the chain. So we start to get these wide-reaching issues of muscular tensions and discomforts, not to mention the fact that your hamstrings and glutes are going to be often weaker than they should be, and under more strain than they should be because they're leaning forwards. And then we think about the signals that go down to those muscles, the glutes and the hamstrings in particular, because this commonly creates issues at the lower lumbar spine, L4-5 and L5-S1. Those muscles are now getting dysfunctional signals coming from higher up as well. So there's all sorts of different issues that are kind of starting to build here. Not to mention then, we've also got those sacroiliac joints we mentioned earlier, that when we drop into anteriorization of the pelvis and we arch our lower back, we end up kind of locking those sacroiliac joints in. Conversely, when we flex and round and posteriorly tuck our pelvis, we open and flare them out and they get a little bit more mobility. This makes sense when we think about it, because if we wanted, for example, to take the posterior tuck of the pelvis and open out the sacroiliac joints to bring our knee all the way up to our chest for whatever movement that we might be doing on the floor or something like that, it makes sense to have a little bit of give in that sacroiliac joint to help translate the large amount of range of motion from the hip joint into a slightly lesser amount of range of motion, or a significantly lesser amount of motion at the sacroiliac joint, and then translate into the lumbar spine. It's just kind of got this dampening effect. And then when we stand up nice and tall and the sacroiliac joint locks in, it's good for force transference. And generally when we're standing up tall, it gives us we want to transfer force effectively. So we don't want too much movement through that sacroiliac. But you're kind of skewing that process because you're always going to be locked in because you're in that anterior position of the pelvis. So something to think about there. Now, that's all kind of set out why anterior pelvic tilt is bad. What are we going to do? What are we going to do to fix it? So reassuring the disclaimer again, if you do actually have it. So this is some of our experience over the years. Typically speaking, people will generally not be much beyond 25 or 30% increase in their anterior pelvic tilt. So the anterior, it's 25 to 30% increased from normal. And generally speaking, you can actually reduce that pretty quickly in 3 to 4 months, maybe 5 or 6 months max, depending on the quality of the spine. You can reduce that back to within normal limits with these exercises and exercises we prescribed in the past with some elements of treatment. But the exercises are really the bulk of what's going to be effective for you, because you're doing them every day. You're really doing good work, essentially. So you can reduce it pretty quickly in that 3-4 months, maybe 5 or 6 months. So that's that. Sometimes people will have a little bit more than that. They'll be up at 50%. And you think about the consequences of that. That's a really anteriorly rotated pelvis. You're talking about, instead of having a 40-degree curve that the 40-degree slope to the horizontal that your lumbar spine sits on, it's all the way up at 60 degrees. That creates an awful lot more shear. You can imagine it, just visualizing that process. The lumbar spine is not sat on a steady base, and therefore this tucking action is very important. You want to make sure that if you do have it measured and you know exactly how much it is increased by, you also understand the relationship with the lumbar spine, because there are going to be knock-on effects in the lumbar spine, because we aren't wired to move L4-5 or L5-S1. We kind of have gross control over this pelvis, and whichever way we shift the pelvis one way or other, that's going to have a knock-on effect on the curvature of your spine higher up. So that's something to bear in mind and fully understand. And the most important thing is that you do these exercises and these movements for a period of time, and then you reevaluate. It's madness when you see someone who's been doing these pelvic tucks for the anterior pelvic tilt for the last 3 years or 2 years or whatever it may be, and they've been doing them religiously, and go, why isn't my back better? Well, maybe you didn't even have it in the first place, and if you did, even if you did, you've probably got a posterior pelvic tuck issue right now, because there's been no real evaluation. Now, if you're getting diagnosed with these things, you should have a pathway for how long you're going to have to do these exercises in order to make them effective effective and bring you back to within a normal position. And that should be some sort of evaluation process, or at least have a timestamp. Say, hey, look, typically speaking, you do this for about 3 to 4 months, and then you just want to stop doing those and focus more on just stability. And this is one of the reasons in the program we talk mostly about just focus on being stable. So the exercises themselves. Now, in the accompanying article, we went into a lot of detail, so you can always check that out using the link under here, or if you're watching it on the website, just go scroll down where we go through how to do these specific exercises. But I'm just going to touch on them from a principle point of view to help you guys understand what you're going to be doing and why you're going to be doing it, so you can sort of move forwards with a better understanding. So the first thing is going to be the wall drill. The wall drill is just standing against the wall with your heels, your bum, your middle back between the shoulder blades, and your head touching the wall, so you get some idea of what standing upright feels like. For some of you, that's going to be, that's a bit peculiar. So that's the first thing. And that wall drill is very, very simple to do, and you do this as a practice. It's not changing anything, but it's starting to get you up here engaging mentally with the process. And now that gets stacked with the chest pop and core engagement. And when you're standing against that wall, you're going to place your hands just below your belly button. And as you kind of straighten yourself up, just press in gently on that, just below that belly button on your core, to really engage that core muscle. And as you do that, you pop your chest out at the same time. That engages some of the musculature on your back, engages your core nicely, and it's going to start to help you resist the dropping forwards of your pelvis. And then really just hold that position. You can do it for 20, 30 seconds. You can do it for 10 seconds. You can do it as and whenever you walk around the house or around work, maybe not so much work, but around the house certainly, and you've got a wall, just stand yourself up against that wall, set yourself in that position, do the chest pop, do the core engagement, and don't allow your pelvis to rock forwards. A lot of this is preventing you subconsciously allowing your pelvis to drop forwards into anterior rotation without you being aware of it. So you're starting to become more aware of that position, and you're doing this as a practice. It's not getting you stronger, but it's getting you more aware. The next one, which is kind of a bit of a hybrid, and that's where you're going to lie on the floor. And you imagine the same sort of position that you were just stood in. But here, you're going to lie on the floor with your knees bent, and you're going to do a posterior pelvic tuck and engage that core. You can, again, pop your hands on your tummy again here. You pop your hands on the core, and then you're going to really hold that engagement so you're not allowing yourself to pop forwards or go into anterior rotation. And you're going to slowly lower one leg down to the floor, so straighten one leg out, keeping your pelvis nice and steady. And you should feel that it might be pulling, if you've got some tight hip flexors, which we'll get onto in a moment, that it might want to pull your pelvis anteriorly. This is sometimes why people get pain when they lie flat on the floor. So you straighten the one leg, and then once that one's locked in and you press it down into the floor a little bit of pressure down, keeping your core nice and tight, keeping that chest pop even though you're lying on the floor. And then you straighten the other leg down. You're holding that pelvic tuck whilst you're then now straight, as if you were standing against the wall, but you're on the floor. And what you will feel when you do this correctly with the appropriate engagement is a nice, strong engagement of that lower abdomen, holding and bracing and preventing your core from tipping forwards, your pelvis from tipping forwards as you do that movement. You'll feel other muscles engage. You'll feel your hamstrings engage a little bit, your back muscles, the core in general, as you do this. And then you just lie there for a moment. Again, you can do this for 5-10 seconds. You can hold it for a bit longer and then bring the legs back up one at a time. You can do this for reps. This is helping you really get that control over the pelvis. And then that's coupled with you thinking about it more readily on a daily basis when you're doing the wall drill and the chest pop and core engagement exercise. And it's going to start to get the cogs going. Now, the next part is about that strengthening and stretching balance. And we address the first thing, which is going to be strengthening. And that is going to be using an exercise like the hip hinge and the hip thrusters. Hip thrusters could also be replaced by bridges on the floor as well. The big mistake that people make when they do these is they allow the pelvis, as they come up to the upright position, be it the hip hinge, which is similar to a straight leg deadlift, or with it, whether it's the hip thruster or bridge on the floor, is they allow their pelvis to rock forwards. And often these are taught in certain environments to help focus on the glutes or the hamstrings, as the case may be, with doing excessive pelvic tuck backwards. And what I would ask instead is you to be more aware of the movement itself and just prevent yourself from rocking into anterior rotation. So if you want to do a slight posterior pelvic tuck, fair enough. But again, once we've evaluated the change that this has made in our spine, we need to eliminate that posterior pelvic tuck going forwards from a long-term point of view. But we might, let's retake the hip hinge to start with. We might want, as we come up, as you're coming up through the hip hinge and straightening your body up, just make sure that you keep that engagement that you had on the pelvic tuck exercise earlier so that your spine stays nice and straight and you don't drive your hips through forwards of your center of mass as you get to the top part of the hip hinge or the deadlift or the straight leg deadlift movement, because that's where your back arches, your pelvis goes anterior, and you create trouble for yourself. So you're learning to eliminate that innate or that natural tendency that you've developed to drop into anterior pelvic tilt at the start of the movement or at the top of the movement on the hip hinge. Again, details in the accompanying article on a little bit more on this, but I'm just covering it here for you guys now as well. When we're talking about the hip thrusters or the bridges, again, the common mistake here, which really bothers people with back pain, and even if you've got anterior pelvic tilt, allowing this to happen will be particularly bad for you because you close the holes and you increase the extension, you increase the anterior pelvic tilt when you do this wrong or in an incorrect manner. So when we're doing the hip thruster or the bench, the bridge on the floor, as we come up through the movement, we want to make sure we are controlling our core and preventing the pelvis from going forwards. Think about that rather than, or at least to start with, try and think about that. And if you absolutely can't control it there, then yes, do a posterior pelvic tuck before you initiate the movement and then go up. You will feel as you get towards the top of the range of motion that feeling we discussed earlier in the pelvic tuck exercise on the floor starts to come in, and the front lower section of your core starts to feel like it's under tension because you want to instinctively drop your pelvis into anterior rotation. So you're working to stop that happening as you get to the top of the exercise, and as a consequence you'll feel probably a little bit more engagement of your glutes and hamstrings in the process of doing that. Now, the reason we've chosen those two exercises is because the hip thruster or the straight leg deadlift approach is generally going to hit your hamstrings a little bit more, and the hip hinge is generally going to hit your hamstrings more, and then the hip thruster or bridge is generally going to hit your glutes a little bit more. So you're kind of covering both your bases. And if you're working with those exercises to increase the strength over time, that's going to deal with the weakness in those areas that is part of this sort of anterior pelvic tilt matrix. Then we get onto the stretching. So the stretching, we've got a couple of things here, but really we're only targeting two key areas. We're targeting the psoas muscle in particular, so a pure hip flexor, and then we're targeting the rectus femoris stroke sartorius through a different type of stretch or a modification of that stretch because they run across the hip, but also down into the knee as well. So we've got the standard hip flexor stretch, which is just going to be getting into a lunge position on the floor, lunging forwards, dropping your pelvis. Again, more instructions on the website. And then we've got the couch stretch, which is a great option, which you can do next to a bed. You can do it next to a sofa. I personally find doing it in the lounge, for example, with your back leg up against the seat of the sofa, so your foot can kind of hang off the edge here. It's a little bit more comfortable personally for me. And then you're straightening up to get the stretch through those relevant muscles on each variation. So the psoas a little bit more, and then the rectus femoris and the sartorius in the second case. And you will find with the couch stretch variation, you're going to feel a lot more down the front of the thigh compared to the initial hip flexor exercise, which is going to be a lot more in the groin area. A couple of ways of doing this. Number one, standard, is just going to be 30-second holds. Doing that day in, day out over the course of time as you're doing the other strengthening work, as you're doing the other practice work that we discussed earlier, is going to be really helpful for you. Then you can also look into doing PNF type stretching, which is going to be fiddling with some of the neurology between the muscle receptors, muscle stretch receptors, and the tendon receptors. And that's whereby we hold a stretch for about 10 seconds. We contract the muscle so to try and come out of the stretch, but don't. So it's an isometric, so it's a static hold. So for example, if you're in the couch stretch position, you might try and straighten your leg against the couch. The couch isn't going to move, or if you're doing it against the wall's not going to move, but you're activating the rectus femoris muscles. You hold that for 10 seconds, and then you relax, and you'll find instantly you can go a little bit further. The final variation you can do from a stretching point of view is also long hold, which works well. And that's where you're just kind of really getting comfortable. You're holding that stretch for around about 2 minutes or so. And for that, I would really encourage you, get some supports. Maybe it's a chair or a stool to lean on, so you're really comfortable in that stretch position. You're not having to work hard to hold yourself there on the front leg, for example, and you can just relax, let the stretch come through and enjoy. So now we've worked on all areas. We worked on the mental control with those first couple of exercises, thinking about your posture, being aware of what it feels like in a safe environment, standing against the wall, lying on the floor with the pelvic tuck exercise. Then we've got the strengthening component. We're working on those hamstrings, working on the glutes and the muscles that kind of resist the pelvis dropping forwards into extension. or into anterior rotation and the lumbar spine into extension. And then we've got the stretching component, working to stretch and open out those muscles on the front of our hips that have been pulling on our spine and pulling our pelvis forwards on a daily basis. Ultimately, you also want to make some activity modifications. So if you're sat at the desk all day, you need to make some changes there. That's important. But if you can put this into a little package and do it as part of your daily routine, plus you're obviously doing your standard strengthening work to build general resilience of your lumbar spine and of your hips and some other general flexibility work, but you're just working disproportionately in these areas to kind of build them up a little bit, you're going to really find you make some significant improvement in your anterior pelvic tilt. And then you must evaluate. Once you've evaluated and you've got the habit of how you stand correctly, you know how to stand correctly, you can get it verified on imaging to say, hey, yes, I have actually made improvement. My pelvis is now within normal limits, normal range. I'm more conscientious. Once you're conscientious, you're good. You don't need to, unless you fall into bad habits, but you shouldn't do that, hopefully. And you can focus more on stability, focus more on building strength and resilience through your spine, using the principles like what we teach in the Back in Shape program, not trying to change the pelvis one way or the other, but just focusing on providing good support. And you can eliminate any sort of pelvic tucking or posterior pelvic tucking that you are doing as part of your exercises, because that is the root cause of so many people getting in real struggle. And I know we got a lot of members that watch the podcast, and we talk a lot about posterior pelvic tucks being a real problem. And it was something I was thinking about in this particular episode. We talk about it a lot, but most people don't have anterior pelvic tilt. So this is for that small number of you that actually do have it verifiably. Those of you that don't have it, you don't ever need to be doing these sorts of pelvic tilt exercises. And those of you that do, you do them for a short period of time so they're effective, and then you stop doing them. Think of it just like a medication. If you're unwell, you might be taking some pain relief or some cold tablets, or maybe your child's unwell, they have some Calpol or whatever it is for a short period of time until the job is done, and then you stop it. Same thing with the pelvic tilts and some of those nuanced things that we wouldn't normally recommend to you guys if you were generally in the program and didn't have a proper formal diagnosis of anterior pelvic tilt done properly. Hopefully by now you've got a much better understanding of anterior pelvic tilt. I know it's something that bothers a lot of people, but most people don't actually have it. If you do, and it's been measured appropriately, hopefully you can use some of these exercises that we've talked about today to set out a plan over the next 3, 4, maybe 6 months to then reevaluate that at that point to check that they have done the job. You've got to be conscientious. It's not just about doing the exercises. You've got to think about it. That's why that first part was there. You've got to then do the strengthening, and you've got to do the stretching. And once you've done, then you can move on to focusing on a more balanced approach and eliminate some of those extra nuances that we had to do while you had the anterior pelvic tilt. Hopefully this has been helpful. If you've got any questions or anything's not clear, please do post that in the comments below, and we'd be happy to read those and reply to them and give it a little bit more guidance. Thank you very much if you've watched it this far. I do hope it's been helpful. And if you know someone else that's struggling with their anterior pelvic tilt, consider sharing this one with them. Hopefully it'll give them a fresh perspective and maybe prompt them to do some of the exercises and some of the practices, or maybe get it evaluated more thoroughly so they know they're doing the right things, and if they don't need to do them, they can do other things instead. Thanks so much for watching, and we'll see you in the next episode.